Hi, everyone. Welcome for those of you joining us for the March Med School Café featuring Dr. Hunter. We are going to start with housekeeping notes. So everyone's currently on mute, and feel free to type any questions in the chat box as we go along. And when we get to the Q&A section, you're welcome to unmute yourself and ask your question directly. But before we start, we want to ask everyone to take a few minutes to take some polling questions. We're going to do a pre-poll before the presentation starts and a post-poll after the presentation, so that we know how you are all doing with the information we're trying to convey. So I'm going to launch those, and it's 6 questions. So if you're joining us from Zoom, you can answer those 6 questions quickly, and then we'll have Dr. Hunter introduce himself. So you should be able to see them now. Just 6 simple questions, and go ahead and get those submitted.
I'm still waiting on the questions. Have they appeared?
They are launching now. Do you see them?
Yes, I see them.
Perfect. Thank you. All right, first response. Thank you, guys. Yep, for anyone just joining us, we've got a poll on the screen, so take a few minutes and submit those questions. We'll let it run for about 2 minutes so we can get everyone's responses in, and then we'll start the presentation. All right, we're almost halfway there to our polling. We'll let it run at least another minute, give those folks who just joined a couple of minutes to submit their responses. And all of your questions, all of your answers are anonymous, just in case you were wondering. Let's see, we're at about 60%. Let's see if we can get to 75. All right, everyone, we'll leave it about 10 more seconds, and then we'll close out the poll. Anyone just joining us, we have a poll on the screen right now. You can read through quickly, submit your answers. Looks like we're at about 85%. We'll give it about 10 more seconds. All righty, thanks everybody. We're gonna close it out, and you'll have an opportunity to see the same questions again at the end. All right, thank you, Dr. Hunter. You can take it away.
All right, can everyone hear me okay?
We can.
Good, okay. So I'll get started. Again, my name's Dr. John Hunter. I'm a colorectal surgeon here at South Alabama. Thank you all for inviting me to talk today. I have no financial disclosures for this talk. So March is Colorectal Cancer Awareness Month, and that's one of the reasons we're having this talk. But the point is to really just raise awareness of where we are with diagnosis and treatment of colon and rectal cancer, and what you can do to look out for this and recognize symptoms and how to get proper screening and that type of thing. Just a little bit about me real quick. I was born and raised in Mobile. I went to St. Paul's School down the street on Old Shell Road. Then I went to University of Virginia, studied electrical engineering, and then on to UAB for medical school. I did my general surgery residency there. I did a fellowship in minimally invasive surgery there, and then worked as a trauma surgeon and also as a general surgeon at the VA up in Birmingham for a year, and then went on to Houston, where I did a colon rectal surgery fellowship at UT Houston, and then landed right back here at University of South Alabama. And I have to give a shout out to my wife, who I met in Houston, and she's from Texas, but she came to Mobile and is now practicing as a breast surgical oncologist as well. So what is a colorectal surgeon? It used to be known as a proctologist, but we specialize in the surgical treatment of diseases of the colon, rectum, and anus, and these can be benign or malignant. So we're going to talk about colon and rectal cancer today, but we also treat hemorrhoids, fistulas, diverticulitis, a lot of different things. We're board certified in general surgery. That's 5 years of training by the American Board of Surgery. And then we go on and do another, they call it a residency, but you may also know as a fellowship in colon and rectal surgery for an additional year. And we perform colonoscopy. We do office procedures. We do outpatient surgery. We do big open abdominal cases. And the thing that drew me to it was we kind of like to be on the cutting edge of the advanced minimally invasive techniques, so laparoscopy and robotics. This is our team here at South Alabama. So I've got two other partners who are board certified colon and rectal surgeons, Dr. Lee Grimm and Dr. Paul Ryder. And then we also have Greer Iliff, who works with us as one of our nurse practitioners. And we have clinics in Fairhope and in Mobile. And I'll put the slide up at the end with our contact information. So the outline for my talk today, we're going to go over what colorectal cancer is and what causes it, and then discuss who is at risk for colorectal cancer and what you can do to prevent colorectal cancer. And then we're going to talk about screening and detecting colorectal cancer. And last, we'll talk a little bit about treatment. My resources, a lot of the resources for the talk today are shown here. So the American Society of Colon and Rectal Surgeons has a great website with a lot of good information, as well as the National Comprehensive Cancer Network, the Centers for Disease Control and Prevention, and the American Cancer Society. So a lot of my stats and info come from these sites. So what is colorectal cancer? So we'll start off with some anatomy. This is the anatomy of the abdominal cavity. So you have the liver there, and then the guts, right? So we eat and food goes through the esophagus into the stomach, and then through the small intestine on into the colon. And the colon starts on the right side of your abdomen, goes up, across, down, and then to the rectum and out. And that's where stool comes out, where you have a bowel movement. So we zoom in, the colon and rectum are actually two separate organs, and that's going to be important later on when we talk about treatment. But they're one continuous tube. So the cecum is the first part of the colon. Then we get to the ascending colon, transverse colon, descending colon, the sigmoid colon, and then the rectum. And the colon has a lot of jobs, but its main job is to take liquid stool. So your small intestine is going to take a lot of the nutrients out of food and dump liquid stool into the cecum. And then as the colon propels that forward, it's going to absorb a lot of that fluid back into your body to form solid stool. And that's so the main job of the colon is to absorb water from stool contents and store stool and release it when appropriate. So cancer of the colon and rectum starts off as a precancerous polyp. And these polyps form in the inner lining of the colon and rectum, as seen here. And this is actually a view from a colonoscopy showing a polyp. And these polyps can have a stalk like this one, so sort of a tree, or they can be more flat, or we call them sessile, within the wall of the colon. So what is a polyp? So polyps are a mushroom-like growth that grows in the lining of the colon. And these are caused by cells in the lining of the colon that are reproducing in an unhealthy or disorderly way. And you don't just have a polyp that's immediately cancerous. They're sort of on a spectrum. So early on, a polyp is just sort of extra growth of cells. And then they start to take on a different appearance. They're growing a little bit more out of control, and they're forming a little bit differently. And we call that dysplasia. These are still technically benign. They're not trying to spread anywhere, but they're sort of on the road to becoming cancerous or malignant. eventually they can grow segments that are technically malignant or adenocarcinoma. And these are cells that are really not inhibited at all and are growing out of control. And then they can start to grow into the wall of the colon and become invasive cancer. And what does that look like? So all, cancers are what we call staged because some cancers are more advanced than the others. So the earlier stage 0 and 1, are typically confined to the colon wall, and even in stage 2. Stage 3 is where we start to see the cancer spread to the lymph nodes, which are nearby in the colon. And then stage 4 is where it's advanced through the lymph nodes and spread to other parts of the body. So normally we see that in the liver and in the lungs. So the stage of the colorectal cancer depends on the depth of invasion, which means how deeply the polyp, now tumor, now cancer, has grown into the wall of the colon, the spread to nearby lymph nodes, depicted here in green, and then the spread to other organs, the liver and the lungs. And I'm using the term colorectal cancer. Colon and rectal cancer are actually two different entities, and we'll get into how those are different in a little bit. The colon cancer refers to cancer seen anywhere from the cecum to the sigmoid colon, and then rectal cancer is, of course, cancer of the rectum. But for the sake of this talk, we'll refer to colorectal cancer and abbreviate it as CRC, and then I'll make distinctions later on when needed. So why is this important? So in 2019, colorectal cancer was the second leading cause of death from cancer in the United States. That's behind lung cancer. And in 2020, there were predicted about 105,000 new cases of colon cancer and about 44,000 new cases of rectal cancer. Now, as medicine has advanced, the incidence of colorectal cancer has decreased per 100,000 people. You can see there from 60.5 in 1976 to 46.4 in 2005. And we think a lot of this is from, and along with this incident decrease, mortality has decreased by over 50% since 1990. So a lot of this is thought to be from better screening and better treatment modalities, which would make sense. So the next question is, what causes colorectal cancer? So a little bit of physiology here. So our genes are made up of our DNA, and that's really just the simple way to think about that is as a recipe book. And you pick up the recipe book and you translate that recipe into a dish, and that's your normal protein. And then you serve that dish and everybody's happy. So you have normal colon cells. So in our body, our genes are used as a code or an instruction or a recipe to make proteins. And then proteins have thousands and thousands of different functions throughout our body, but they go on to make up, in this case, normal colon cells. And what we see here is a view of normal, healthy inner lining of the colon. We call that the mucosa, seen under a microscope. And this is a view of that seen on a colonoscopy view. So with colon cancer or rectal cancer, these genes or these instructions or these recipe cards are mutated. And it may just be one little area that mutates, and what that causes is either an abnormal protein to be formed or no protein at all. And that can lead to abnormal colon cells shown here. These are that same location, but these are cancerous cells of the inner lining of the colon, and that's what that can look like on endoscopy. So these cancers form by malformed proteins from mutated genes. And these mutations in genes will lead to, will eventually transform into abnormal protein cell formation, eventually transform into cancer cells. And cancer cells have uninhibited growth and spread, and that's why they're problematic. So that's sort of a basic look at what colorectal cancer is. So the next question is who is at risk for colorectal cancer? So what risk factors are behind developing colorectal cancer? Well, age is one. We know that the risk increases after age 50. family history of colon cancer is definitely a strong risk factor. If you have a first-degree relative, meaning a parent or a sibling or a child with colorectal cancer, then your risk is doubled over the normal population. A personal history of polyps or ovarian cancer or previous colorectal cancer, or, and this is important, inflammatory bowel disease such as Crohn's or ulcerative colitis, all put you or put that patient at an increased risk for developing colorectal cancer. There's also inherited risk, which we'll talk a little bit more about here in a second, but that would include syndromes known as Familial Adenomas polyposis, or FAP, and also Lynch syndrome. Race also can be a risk factor for developing colorectal cancer. So in the United States, we do know that African Americans have an increased risk of developing and dying from colorectal cancer. Ashkenazi Jews, who are of Eastern European descent, have one of the highest colorectal cancer risk of any ethnic group in the world. And some of these come from socioeconomic factors, which is the case with African Americans in the United States, and some come from genetic factors, which is the case for Ashkenazi Jews in Eastern Europe. So a little bit about genetics. So 10 to 30% of patients who show up and are diagnosed with colon cancer will have a family history of colon cancer. And this suggests one of two things or a combination of those. There's either a hereditary contribution, meaning genes were passed along in that family, or there's common exposures or shared risk factors among family members. Maybe that's socioeconomic status, access to healthcare, obesity, all things that can lead to increased colon or rectal cancer within a family group. Or maybe there's some combination of both. If we look specifically at genetic syndromes, there are two main genetic syndromes that we look for. One is called Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer, or HNPCC. And we know that these patients, this is passed along through families, through generations. These patients are at increased risk of developing colorectal cancer earlier. And these patients benefit from earlier screening of the family members. So if a patient is found to have Lynch syndrome, if we can diagnose them, or if we diagnose them with Lynch syndrome, then we can help their families get earlier screening because we know that they are at higher risk of developing an earlier cancer. And also with these patients, if a cancer is found, they may have different treatment options over the normal population. The other syndrome we talk about is familial adenomas polyposis. And this is a syndrome that's passed through generations, and they develop nearly 100% chance of developing colorectal cancer. These patients in the first syndrome, they don't have a lot of polyps on colonoscopy necessarily, but in FAP, or familial adenomas polyposis, these patients will have hundreds and hundreds of polyps as early as their late teens or early 20s. And if we diagnose somebody with FAP, we can help their family out as well by prophylactically removing the colon and rectum at an early age, usually in the late teen, early 20s, to prevent what eventually will occur, colon or rectal cancer. And we certainly have these types of patients in Mobile. Myself and my two partners, we all have our small group of families that we take care of with this, and we've all operated on. Typically what we'll see is we'll see a mother or father come in, get diagnosed with cancer, they have FAP, and then a few years later, we may be operating on their children when they reach the appropriate age. And at South Alabama, we work really, really closely with the genetic counseling department. I'll talk about our tumor boards here in a minute, but the genetic counselors work very closely with us. We refer them a lot of patients. We do a lot of testing for these disorders to make sure we pick them up and help these families out. But as I mentioned, about 10 to 30% will have family history. So that means about 75% of patients who are diagnosed with colorectal cancer are sporadic, meaning they have no family history at all, no identifiable inherited disorder. So what can you do to prevent colorectal cancer? Well, obviously, you can't reverse your age. And there's, certain risk factors that we talked about, you can't reverse, but some you can. So we talk about lifestyle modifications of avoidable risk factors. So all of these things have been associated with increased risk of colorectal cancer, cigarette smoking, lack of physical exercise, obesity, alcohol use. You can see where your cancer risk can increase upwards of 50%, depending on how much alcohol you drink. A diet low in fiber or high in red meats has been shown to increase the risk of colon and rectal cancer as well. So increasing fiber in your diet and trying to eat more lean meats or fish can help with that as well. There are some protective factors against colorectal cancer as well. So increased physical activity can be protective against colorectal cancer. Aspirin has been shown to lower the risk of colorectal cancer. You have to have used it for 10 to 20 years, and it does have risk, right? So stroke and GI bleeding can occur with aspirin use as well. Combination hormone replacement therapy, so estrogen and progesterone, does lower the risk of invasive colorectal cancer postmenopausal women, but it also has associated harms of increased breast cancer, heart disease, and blood clots. But one of the biggest protective factors against colorectal cancer is polyp removal. And we'll talk a little bit about how that works shortly when we talk about screening. So how can you detect if you have colorectal cancer? Well, you can get symptoms with colorectal cancer, and I'm going to list a few of those here. So blood in the stool, either in or on the stool, certainly concerning for colorectal cancer. A change in your bowel habits, so all of a sudden you're having more diarrhea or more constipation, or maybe not feeling like you've completely emptied. Maybe you notice the stool is becoming more narrow. General abdominal discomfort like bloating, fullness, and cramps can all be associated with colorectal cancer. More advanced colorectal cancer can obstruct, and then you can develop vomiting, gas pains. Another one we see a lot is just unexplained weight loss. All of a sudden, hey, my pants are a lot looser and I really haven't been working out or exercising. That should trigger in your head or your primary care doctor's head to go looking for certain cancers. New onset fatigue or tiredness. Normally, if you're active and now you're not getting through those activities as well as you used to, that could also be a sign of anemia or blood loss. And when we're found to be anemic, one of the first places we look is in the colon and rectum. But a lot of times, colorectal cancer, especially early on, can have no symptoms at all. And so ideally, you want to know if you have colorectal cancers before there are symptoms, because that means you're catching it early. And that's where screening comes in. So screening means you're looking for a cancer before a patient develops symptoms. And the goal is to find that cancer at an earlier stage when it's easier to treat. We know that screening of average risk individuals can reduce colorectal cancer incidence and mortality by removing polyps before they become cancer and detecting cancers at earlier stages. And we also know that patients with colorectal cancer detected at an early stage have a 90% relative 5-year survival rate compared to those found later stages with lymph nodes or with metastatic disease. So catching these early is very, very important. In fact, approximately 63% of colorectal cancer deaths can be attributed to non-screening, meaning they've showed up with a cancer and they've never had screening before. So early detection can absolutely save lives. So who should be screened? Well, everyone. Average risk patients are patients with no history of colon polyps, no history of inflammatory bowel disease, no family history of colorectal cancer or advanced polyps. And the traditional teaching is, you get your colonoscopy starting at age 50. However, recent data in the last few years has actually shown that the incidence of colorectal cancer in younger adults, so less than 50, has been increasing about 2% per year since 2003. And we're not really sure why this is. There's probably some environmental and socioeconomic factors. But because of this, more and more societies are coming out and recommending earlier screening. So the American Cancer Society is now recommending average risk colorectal cancer screening begin at age 45. And like I said, more societies are starting to recommend this, and insurances are starting to follow through as well. And there's been a lot of recent talk about this. The actor Chadwick Boseman from the Marvel Black Panther movie, he died last year at age 44 of stage 4 colon cancer. So he was filming these. None of his friends or coworkers knew And his death has certainly raised a lot of, publicity and concern and awareness for colon cancer in the younger population. So we talk about average risk patients. There are also patients who have an increased risk of developing colorectal cancer. And so they may need earlier screening, earlier than 50 or 45, or more frequent screening. And these patients are patients who may have a personal history of advanced polyps found on previous colonoscopies, may have a history of colorectal cancer, or like I mentioned earlier, Crohn's disease or ulcerative colitis, so inflammatory bowel disease. Those patients need to be screened earlier and more frequently because they are an increased risk of developing cancer. Family history. So we talked about Lynch syndrome and FAP. We know that if you have a first-degree relative with colorectal cancer, you should start screening at age 40 or 10 years before their earliest diagnosis, and repeat this at least every 5 years. Now, this may not mean you have FAP or Lynch syndrome, but we don't know about every genetic disorder out there that may lend itself to developing colorectal cancer. So that's why we screen these patients earlier and more frequently. If you've had a first-degree relative with an advanced polyp, then you should start screening earlier, age 40. Another question that comes up a lot is, when should I stop being screened? And the average risk adults in good health with a life expectancy greater than 10 years should continue screening through the age of 75. Now, between 76 and 85, it's sort of a gray area, and that's a discussion with you and your doctor based on your preference, life expectancy, health status, and prior screening history. And then after 85, there are some special circumstances, but it's generally discouraged after the age of 85. That's not to say it isn't done. There aren't good reasons for it, but generally up through 75 to 85 is sort of that gray area. And then beyond 85, generally discouraged. So let's talk about the options for screening for colorectal cancer. So the ideal screening test, if I had a magic wand, I could wave it right now, and I'd get a report out that would tell me exactly each person here on the Zoom meeting, their status, and it was 100% accurate. It didn't cost us anything. None of y'all were harmed, and it took 1 second. That would be the ideal test, right? But no test is like that. So we have to develop tests that are as close to these ideals as possible. And there are several different options for screening for colorectal cancer. And we generally divide these into structural tests and fecal-based tests. So structural tests are going to be detecting polyps using either a colonoscope or imaging. And these have varying degrees of invasiveness. Most of them require some sort of dietary change or bowel prep, and they take time. And the examples would be sigmoidoscopy, colonoscopy, or virtual colonoscopy. We'll talk about these in a little bit more detail in a minute. The fecal-based tests are the ones you see a lot of commercials for, the mail-in tests, where you may do it in your family doctor's office. And these detect signs of colorectal cancer in stool samples. These are non-invasive. You don't have to take a prep for them, and they certainly take less time. And these include fecal occult blood tests or DNA stool tests. And we'll talk a little bit about those right now. So the fecal occult blood test, there's two different kinds. There's the guaiac and the immunochemical or FIT test. The guaiac test, they both work by taking a small sample of stool and looking for blood. The guaiac test, we use these, they're very cheap and easy. Basically, it's a little card that will change color once you smear stool on and apply a certain reagent. You have to collect 3 separate samples. The FIT test is a little bit more sensitive than the guaiac test. Basically, a special liquid is added to a stool sample, and then the machine uses antibodies to detect blood. If either is positive, you'll need a colonoscopy, and these should be done either annually or every 3 years with flexible sigmoidoscopy. Newer to the market, you've probably seen advertisements for this, the stool DNA test. So actually, this is mailed in, the stool sample is checked for DNA with genetic changes that may signal colon cancer. And these are good for detecting cancer in advanced polyps, but not so much smaller polyps. They need to be repeated every 3 years. And if they're found to be positive, you still need to go on and get a colonoscopy. So sigmoidoscopy uses a sigmoidoscope or a colonoscope, which are both essentially the same thing. One's a little shorter than the other, but it's a tube with a light and a camera on the end of it, and it's inserted into the rectum and sigmoid, and the lower half of your colon and rectum are examined. So the sigmoid colon and the rectum. Polyps, if they're seen, they can be removed or biopsied. The prep for this is a lot less complicated than a full prep for a colonoscopy. Generally, no anesthesia is needed. We can do these in the office. They should be repeated every 5 to 10 years, but you should know it doesn't evaluate the entire colon. And if any polyps are found, you should get a full colonoscopy to follow up on that. So a colonoscopy is used as a colonoscope, similar to the sigmoidoscopy, but it goes all the way around to the cecum and examines the entire colon and rectum. And any polyps that are found can be biopsied or removed. This does require the full prep that you always hear about, people groan about the day before, because we have to clean out the entire colon so we can see all the surfaces and make sure that we're not missing any polyps. It does generally require sedation and anesthesia. And typically these are repeated every 5 to 10 years, but sometimes sooner depending on what is found. And this is certainly the gold standard and the most common modality here in the United States. Finally, virtual CT colonoscopy. So this is relatively new. Basically, a CT scan is performed, and then a computer reconstructs the colon images and makes essentially a virtual colon that the radiologist then kind of flies through and looks for polyps. And it's good at detecting polyps greater than a centimeter. It does require a prep, but it doesn't require sedation. There is some radiation exposure associated with it as well with the CT scan. And again, if any suspicious lesions are found, then you'll need a colonoscopy. And these are typically repeated every 3 to 5 years. This is sort of a busy summary slide. We're not going to go through it all, but this gives you an idea of all the available screening tests, their recommended testing intervals, and how sensitive and specific they are at finding colon or rectal cancers or advanced polyps. So once a polyp is found, how is colorectal cancer treated? So say you've noticed some blood in your stool, you go and see a gastroenterologist who performs a colonoscopy, and they find a mass in your colon and they biopsy and it comes back as cancer. What happens next? So typically you'd be referred to a colorectal surgeon. And the first thing we do anytime really any cancer is diagnosed is we need to stage the cancer. So in colorectal cancer, staging is done typically with CT scan, and that involves a CT scan of the chest, abdomen, and pelvis looking for any evidence of spread. In rectal cancer, we also use MRI, and I'll talk a little bit about why in a minute. But the idea here is to look for any spread of the cancer beyond the colon or rectum. And that in turn will tell us, that initial stage will tell us what needs to happen next in the sort of the treatment algorithm. So remember, we talked about stages of colon cancer or rectal cancer, stage 0 all the way through stage 4, meaning it's starting to grow into the colon wall, into the lymph nodes, and then beyond, maybe to the liver and the lungs. So how do we treat these? Well, treatment again is based on stage. So the very early stage cancers can sometimes be treated endoscopically. Sometimes we get lucky and the cancer is found very, very early, and it's been removed completely endoscopically, shown in this image here on the left. And then you just need surveillance. We'll talk a little bit about that in a minute. With some rectal cancers too, we can remove the tumor through the anus. In this picture here, these are laparoscopic instruments through the anus into the rectum. We can actually cut the tumor out and close everything back up, go home that same day. Really very little, if any, discomfort associated with that procedure. And if it's an early enough stage, then that may be all you need. And so this is really where you benefit in finding these cancers early before they present with symptoms. In the early and mid-stage cancers, we're talking about stage 1 through stage 3. And with stage 1, some of the other options I just showed can be an option. But generally, we start to separate colon and rectal cancer out because the treatment modality is a little bit different. So with colon cancer, like the patient that came to my office I just mentioned, surgery is going to be the first step in treatment. You diagnosed it, you staged it, made sure there's no spread anywhere else. The next step is surgery. After surgery, you may or may not need chemotherapy if the lymph nodes are found to be involved, or if the tumor itself exhibits certain high-risk features. So we don't really know what the final stage of the cancer is in terms of lymph node involvement until after surgery, until the pathologist has had a chance to examine all the lymph nodes and see if there's any spread. And with colon cancer, radiation usually is not needed. There are some special cases, but usually radiation is not a treatment modality for colon cancer. For rectal cancer, it's a lot different. And this goes into the anatomy of the rectum and the location and the way the lymph nodes are surrounding the rectum. But in certain stages of rectal cancer, you may need chemotherapy combined with radiation before surgery. And what we know that this does is help decrease the local recurrence of the cancer in the future. So patients who go straight to surgery versus patients who have chemo and radiation first, they've done those studies many years ago and found a benefit of local recurrence in chemo and radiation up front. A lot of these patients, however, will need 4 to 6 months of chemotherapy after surgery as well. We at South Alabama, we are definitely applying new kind of treatment algorithms that are becoming more and more popular throughout the world. One's called total neoadjuvant treatment, where this allows for the patient to get all of their chemotherapy and radiation up front before surgery, and then surgery is held over until the very last modality. And this has a lot of advantages. Personally, I've seen in a lot of my patients, a lot of times after a big operation, you may be just a little too tired to face surgery, and it's to face chemotherapy. Also for rectal cancer, we sometimes have to do a temporary ostomy. I'll talk a little bit more about that in a few minutes, but the patients have to have that ostomy while they're getting chemotherapy after surgery, and so they have to wait for the chemo to finish 4 to 6 months to get that ostomy reversed. Whereas with the newer treatment algorithm we use here at South with TNT, they get all that treatment up front. They can get their ostomy reversed 4 to 6 weeks after their main cancer surgery and seem to do very, very well. So that's for stages 1 through 3. For stage 4, so remember, this means the tumor is spread most commonly to the liver and the lung, or the lung. This usually involves chemotherapy up front, surgery with removal of the original tumor, and the areas where it's spread can often be offered. And then also with stage 4 colorectal cancer, we may use other modalities such as radiation, radiofrequency ablation, chemotherapy, chemoembolization, may also be employed. There's newer immunotherapies that are used now, and clinical trials are a big part of treatment for advanced stage 3 and stage 4 cancers. And at South Alabama and the Mitchell Cancer Institute, we enroll patients in clinical trials very frequently. So once you've had your cancer treated, you enter into what's called surveillance. So this is after treatment care. And basically this is just looking very closely for the next 3 to 5 years to make sure that there's no signs of the cancer coming back. This includes a doctor visit every 3 to 6 months for 2 years, and then every 6 months for a total of 5 years. You'll get labs drawn at those doctor visits. You'll also get a CT scan every 6 to 12 months for 5 years. And then colonoscopy is going to be repeated about a year after surgery, and then every 3 to 5 years, depending on what's found at that time. So I've mentioned radiation, I've mentioned all different kinds of treatment techniques, chemotherapy, pathologists, radiologists. A lot of doctors and staff work really hard to take care of these patients. And at South Alabama, we have what's called a multidisciplinary tumor board that meets every 2 weeks. This is made up of colorectal surgeons, medical oncologists, radiation oncologists, liver and lung surgeons, pathologists, radiologists, genetic counselors, nurses, nurse practitioners. And we meet every 2 weeks and discuss patients individually, put up all of their information, images, pathology, and talk about the treatment plan. This is a screenshot of our most recent tumor board. It used to be in person. Now, of course, we're doing it over Zoom. And this allows for really sort of customized care for the patient, higher quality care, good communication between the practitioners. And this is really the standard that's coming along out there. And we've been doing this at South for about 4 or 5 years now. And so if you or a family member comes to South Alabama to get your colon and rectal cancer treated, you will be seen by all of these doctors one way or the other through a multidisciplinary tumor board or in person. So I want to talk a little bit about surgery for colon and rectal cancer, since that's what it's done, and then we'll wrap it up. The majority is done in a minimally invasive fashion. I mentioned that's kind of what drew me to colorectal surgery. We do a lot of our operations laparoscopically and robotically. Typically, these operations will require a 2 to 3 night hospital stay. We do a lot of nerve blocks here at South. Us and the anesthesiologist will do a block that can last 2 to 3 days and really help with postoperative pain, minimize that pain. And many people are back to relatively normal activity within 5 to 10 days. I should mention the stoma or the bag or the ostomy. The vast majority of colon cancer cases will not require an ostomy. And kind of illustrated here, a bag is adhered over that, and that collects stool. So obviously it's not something people desire. And these days it's not required for a lot of colon and rectal cancer surgery. Some rectal cancer cases will require a temporary ostomy. And permanent ostomies may be required in very, very low rectal cancer cases. These are rectal cancer cases that are so low that they're involving the sphincter muscle, which keeps the rectum closed. But these days, with the technology, with robotics and minimally invasive procedures and some of the more advanced pelvic surgery techniques that we employ here, we can save, we call it sphincter sparing surgery, and restore intestinal continuity so patients don't have to have a permanent bag. These are just some illustrations of what colon resection looks like at a sort of high level, illustrated level. And anastomosis is just a job security term for making a connection between two pipes. So you can see here that a cancer here in the transverse colon is removed, and then we put those back together, and stool still flows on through the rectum and out. This shows an example of a cancer removed and an ostomy bag is employed. So the tumor is removed, and then now food will come through here and then out the stoma into the bag. And this is just a simple depiction of rectal cancer surgery, where we're able to take out the rectum and then use this left colon to come down here and kind of become the new rectum, and intestinal continuity is maintained. A quick word on open versus laparoscopic versus robotic. This is not me. This is just random Google search guy. But open surgery, traditional surgery, it employs an incision through the midline. And this can certainly cause some more pain to recover from, higher risk of hernia formation and wound infection. Whereas laparoscopic and robotic surgery employs much smaller incisions. These are typical incisions like you would see with a gallbladder or appendix. This is a patient of mine. We took their sigmoid colon out, and we do some newer techniques here at South, extracting the specimen through the bottom instead of through a separate incision. So this person has 3 8-millimeter incisions and 1 12-millimeter incision. And this just leads to less wound infection, out of the hospital faster, less pain, quicker return to normal function, and less hernia formation in the future. And this is about the same number of incisions you would get to have your gallbladder removed. At South Alabama, we use the Vinci Robot. We have 2 of these here now, thanks to the Mitchell family and generous donation a few years ago. And the term robot is a little bit of a misnomer. This is the part that's at the bedside, and this is the part that we as a surgeon sit. And the robot has no control. We control every single move it makes. It's not making any moves on its own. So, but it does allow for much, in my opinion, much higher quality view, easier dissection in really difficult spaces, and allows us to do a lot of big surgery and with small holes. So to finish off, I just wanted to do a quick case with you guys. So this is an 84-year-old gentleman who's very active 84-year-old. He works in his garden and wood shop every day, and he started to have increased fatigue. And remember, I talked about fatigue is usually associated with anemia or low blood count. So his doctor did one of the guaiac stool tests, and it was positive for blood. So this led to a colonoscopy that revealed this mass in his right colon. So he came to me, got a CT scan to make sure there wasn't any evidence of spread, and then there wasn't. So the next step was surgery. So we performed a robotic right colectomy on him. So I'm going to show you a quick video here I put together. This just shows the robotic instruments, how we're able to manipulate those inside. I have control of all three arms and the camera. And here we're working on getting his lymph nodes dissected out. And you can see how good the view is there. I can zoom in real far and see exactly what I need to see. That's some of his other small bowel down there below that we want to leave behind. So we're just taking the lymph nodes off of that small bowel. This is an instrument, a vessel sealer, which is used for, it's an energy device that kind of seals and cuts at the same time, and that decreases the amount of blood loss during the case. And you can see that that instrument moves just like a human wrist, and so it really gives us a lot of mobility in the abdomen. Here, we've got the colon, the transverse colon in the small bowel, and I'm going to lay that next to it. And then we use a stapler to pretty much weld those two pipes together. And the stapler will fire, and now food will travel from the small bowel to the colon like it normally does. And we've left with that hole, and we can use suturing inside with the robot to close up that hole. So that to the surgeon feels just like suturing with normal instruments outside of the body, but we're doing it inside with the robotic instruments. It's just mimicking our hand and wrist movements. So that patient had a very uneventful hospital course. He went home post-op day 2 and was back in his garden 3 days after surgery working. And his final pathology was stage 2, so he didn't require any chemotherapy, and he did quite well. So just wanted to share with you all an example of kind of what we're able to do here with colorectal cancer treatment at South. And so a quick review. So colorectal cancer is a common but very treatable cancer. Family history and personal history plays a very important role in your risk for developing colorectal cancer. A healthy, high-fiber diet, exercise, and avoiding alcohol and tobacco can lower your risk of developing colorectal cancer. Screening with colonoscopy can prevent cancer by removing precancerous lesions or polyps and detecting cancer earlier when it's more treatable. And treatment for colorectal cancer involves a team, right? So surgery, radiation oncologist, medical oncologist, pathologist, radiologist, all types. And we work together in a multidisciplinary approach. And this optimizes quality of care. It assures up-to-date evidence-based treatment guidelines are used and being offered to the patient, and enhances communication between teams. Surgery for colorectal cancer can often be performed in a minimally invasive fashion with smaller scars and quicker return to normal activity. And finally, a stoma or a bag, which has been sort of a stigma of colorectal surgery, is often not needed and rarely permanent. And that's all I have. So I'm happy. I guess we're going to do the poll again, and then I'm happy to take some questions. Thank you for your time.
Thank you so much, Dr. Hunter. That was an excellent presentation. I am going to launch the poll. Give me 1 second. Okay, everyone who's joining us from Zoom should be able to see the polling questions. We'll open it up for a couple minutes, let everyone submit their responses, and then we'll go over the results and have a Q&A. Thank you everyone for submitting your responses. This is very helpful for us. Let's see, we're almost 50% there. Great. You guys are fast this time. Okay, we're at 60%. Let's see if we can get to 70 and we'll close it out here in a few seconds. Anyone who didn't submit, feel free to go through. There's just 6 short questions. Submit any last minute responses. Okay, I'm going to close it out to give us time for the Q&A. So I'm going to share the results. And Dr. Hunter, I'll let you go through these real quick.
Oh, let's see. Can you put, they just went away on my screen accidentally. Here, I've got the ones you emailed me. I don't know how that happened. I must have exited out. Here we go. There it is. Okay. So the colorectal cancer is the second leading cause cancer killer in the U.S. That's true, behind lung cancer. Colorectal cancer screening is recommended to begin at what age? It's now 45. Is sort of the newer recommendation that's becoming more standard. What age can you stop getting screened for colorectal cancer? So we stop at age 75, but like I mentioned, between 75 and 85 is sort of the gray area discussed with your doctor. And if you don't have any symptoms, it means you don't have colorectal cancer. Obviously, that's false. That we want to find these cancers before you have symptoms. The only screening test for colorectal cancer is colonoscopy. That's false. We went over about 5 or 6 other options. Of course, colonoscopy is the gold standard. And if any of those tests are positive, you'll still require a colonoscopy. And which of these are symptoms of colorectal cancer? So all of these: blood in or on your stool, stomach aches, pain, cramps, or losing weight, and you don't know why. Very good.
Great. All right, everyone, we will stop those and open it up for Q&A. Feel free to type directly into the chat box, or you can unmute yourself and ask directly. I have a direct message to me, Dr. Hunter.
Okay.
Sharon is asking, what type of screening should someone do if they have diverticulitis?
So diverticulitis is not necessarily mean you've got an increased risk for developing cancer. However, if you develop diverticulitis with an abscess, or you may have been hospitalized for diverticulitis, typically once you recover from that, if you haven't had a colonoscopy within the last 5 years or so, you should probably get an updated colonoscopy, because a small percentage of patients who present with diverticulitis with a localized abscess will have cancer associated with it. But just having diverticulitis does not, or a history of diverticulitis does not mean you've got an increased risk of developing colon cancer.
Thank you. And let's see, another direct message from Selena is asking, do you also perform surgeries for esophageal cancer, or is that another doctor?
I do not, no. So that's foregut surgery. That surgery is still done in a minimally invasive fashion often. Dr. Bill Richards here at South Alabama, along with some of the folks in the thoracic group, do those operations.
Great. Okay, I don't see any other questions in the chat. Anyone feel free to unmute yourself. And then Lindsay, are there any questions on Facebook?
Dr. Hunter, I
Yes.
have a question. I work in the prevention realm, and we encourage people all the time to obtain FIT testing if they have trouble or are reluctant to do colonoscopy so that they have some form of screening.
Mhm.
And so we frequently will encourage that with people for them to talk to their primary care about obtaining that. Unless they have a problem, and you kind of go through the list of things, whether or not they have a family history and so forth. But a lot of people will say, well, yes, I can have problems with hemorrhoids. So how am I going to take a FIT test if I have a problem with that? I'm afraid of a false positive. What
Yeah.
do you say in that case? And what are the chances of, it
Well,
just
yeah,
it
so
frequently comes up.
yeah, so if they have a positive FIT test, they need to have a colonoscopy, and
Right.
you could tell them that, you've got hemorrhoids, and that certainly could be causing your FIT test to be positive. But the only way to know is to get a colonoscopy. And I talked about having, younger and younger patients are presenting with colon cancer. So my kind of anecdotal rule in my clinic, if I have a 35 or older patient that comes to me I'm seeing blood in my stool, and they're sent to me for hemorrhoids, and even if they have obvious hemorrhoids on exam, I'll still do a colonoscopy, because you just don't know until you look if there's another cause of that bleeding. So just because your FIT test is positive and you have hemorrhoids, that doesn't mean you can't have cancer. You just have to talk to them about that you could have two problems and they're both causing the test to be positive.
Right. Okay. Thank you.
That's a good question. Let's see. I've got a question here on the chat. Which area of the colon is the most common location for cancer? Is there any reason that can be identified? Is there any reason that can be identified for specific location? So it depends. So most, I don't know, the most common, there's not a most common area. We see a lot in the sigmoid and rectal. That'll catch a little bit more than the majority, or 50% of them. That's why sigmoidoscopy, where we just look at the sigmoid and rectum, are employed. But then certain genetic conditions will cause you to have more cancer on the right side of the colon, which is not seen with flexible sigmoidoscopy. Rare to see it in the transverse colon in splenic flexure, but it really can be anywhere along the colon or rectum. And then your second part, is there any reason that can be identified? I don't think I quite understood the second. Is there any reason that can be identified for a specific location? Basically, all locations can be seen by the colonoscope. And so that's why that modality is employed, to look through the whole colon.
Lindsay, any questions on Facebook?
Nope, none on Facebook.
None on Facebook. Okay.
All right.
Well, thanks everyone.
Yeah, thank you all very much for your time.
And we hope everyone has a great day.